I've been asked to talk about patient selection for mitral TEER, these are my disclosure. For TEER, we have several devices, the MitraClip and Pascal, that allows for edge-to-edge intervention and correction of the leaflet coaptation without annuloplasty. As you know, we treat two etiology of MR. The primary MR, essentially the type 2 with the mitral valve prolapse, and the secondary MR, especially the type 3B, according to the Carpentier classification. And let's start with the secondary MR because maybe it's the more challenging and actually secondary MR, generally there is a myocardial injury with adverse LV remodeling and dilation that cause a tethering of the mitral valve apparatus and therefore causing secondary MR. And then the secondary MR, of course, further worsen the LV remodeling and dilation, and again the tethering of the leaflet. So it's a kind of MR budgeting MR. So it's a vicious cycle here. So what are the guidelines for indication of TR for secondary MR first? Well, first you need to have a chronic severe secondary MR with persistent secondary MR and symptoms. Patients not appropriate for valve surgery, not having end-stage LV or LV failure, because otherwise you should consider palliative care, and who fulfill criteria suggesting an increased chance of responding to TR. And well, the guidelines are relatively vague on this last step. So if you do have all these criteria, yes, TR is indicated. If not, you may consider TR, but with caution. So I summarize here again the criteria that should be considered for patient selection for TR in secondary MR. Again, persisting severe secondary MR and symptoms, not eligible for surgery, no end-stage LV or LV failure, fulfill criteria for likelihood to respond to TR, and finally, of course, considered anatomically suitable for TR. So let's first pause on this definition of severe MR in the context of secondary MR, because for primary MR, we know the criteria that are generally used, an airway more than 40, regurgitation volume more than 60, and regurgitation fraction more than 50%. But for secondary MR, some studies suggest that the impact on clinical outcomes may occur at lower threshold of airway and regurgitation volume with airway more than 30 and a regurgitation volume more than 45. And these are actually the criteria that have been used in the coapted mitral FR. So this is the definition for severe MR or moderate to severe secondary MR, and can be considered as an indication for intervention. And in this study, actually, it is clear that patients who have an airway more than 30, regurgitation volume more than 45, but corresponding probably to a regurgitation fraction more than 50%, because these patients with low flow state, these patients with a secondary MR often have low flow state. So a regurgitation volume of 45 ml actually corresponds to relatively large regurgitation fraction. And so these patients should be considered as having at risk severe or moderate to severe MR. So we know all these results, these diametrically opposed results of the two trials that have assessed TR in the context of secondary MR, the COAP trial that was very positive, and the mitral FR trial that was completely negative. And a priori, this was the same trial design in the same population, but if you look into the details, there are some differences in the trial, and the main differences are that in the COAP, there was clearly more patients with true severe or moderate to severe secondary MR, whereas in mitral FR, there was a higher proportion of patients with moderate MR and maybe less with severe. The other difference is that the LVs in this trial appears to be more dilated in MITERA FR than in COAPT. So maybe more advanced heart failure and LV dysfunction in a MITERA FR versus COAPT. And so, yes, indeed, I think where the TR is most likely to benefit the patient are the patients who have a significant, so moderate to severe MR, so grade 3 or 4, with not too much LV dilation, so and LV dysfunction, so LV anesthetic diameter less than 70 millimeter. That was one of the inclusion criteria in COAPT. LVF more than 20%. On the other end, you know, the patients who have maybe less severe MR, so mild to moderate, are less likely to benefit from an intervention that target MR. Makes sense. And also the patients who have moderate to severe MR or more, but who have advanced LV dysfunction, dilation, well, the benefit is uncertain. So this is what led some investigators to propose this proportionality framework in secondary MR to be able to interpret the differences between the MITERA FR and the COAPT. So this proportionate MR will be an MR that appears more severe than the LV dilation that is disproportionate versus the LV dilation. And the proportionate MR is, well, the opposite, where the MR severity is in proportion with the LV dilation. I have to say that I like the concept. I don't like the way it has been labeled, the terminology that has been used. And indeed, using this concept and the ratio of the ROA to the LV and diastolic volume, the patients in COAPT will be in the severe and disproportionate MR, more likely to benefit from intervention, because here the MR is probably the key factor and the key causal factor of the heart failure. This also has been called, and I prefer this terminology by other investigators, as MR dominant. So MR is the expected main cause of the heart failure. Whereas in the MITERA FR patients, where there is proportionate MR or MR LV co-dominant, then maybe the benefit of TR is more uncertain. So to kind of reconcile this maybe this concept and make it more clinically applicable, we propose this reappraisal of this framework. So the first step is to make sure you have a chronic secondary MR that is at least moderate to severe, so grade 3 or more, so ejection fraction more than 40 or 50%. And then the next step is to assess this LV dilation versus MR severity proportionality. And let's start by the far hand on the right here. If you have extreme LV dilation, you know, very advanced LV failure with LV and diastolic volume index more than 140 ml per meter square, then probably it's too late, and you should consider other therapeutic options in palliative care. On the other hand, you have what was called before disproportionate MR, but what I prefer to call proportionate LV dilation, where there is, you know, this ratio of EROA to LV and diastolic volume ratio is more than 0.14. So there is, I think, some evidence that the MR is causal in the heart failure, and the LV and diastolic volume index so is abnormally high, but not too high, so between 82 and 140 ml per meter square. Then these are the patients who are the most likely to benefit from TR. These are good candidates for TR. If there is excessive LV dilation, where you have the ratio, the proportional ratio that is now less than 0.14, then these patients, well, you're not sure if the MR is an active contributor to the heart failure or a bystander. And so let's say that these patients are less likely to benefit from TR. They may benefit, but you know, it's a bit less predictable. And finally, if you have small LV dilation where the LV is not or minimally enlarged, I always, you know, think that maybe the MR is not that severe, and you should rule out overestimation of MR severity and more optimize the medical treatment. Then the next step once you know the patient is probably a good candidate for TR, is to make sure that the patient is anatomically suitable for TR. And you have this great table that provides the criteria of suitability for the TR, it's for the mitral clip. In the left column, if you have this criteria that in the green zone, these are patients who are suitable for TR neocord. In the orange here, if you have one criteria, that's okay, but if you have several, maybe you should, it's more like a decision to take between TR or TMVR. And finally, if you're on the red here, it's more not good candidates for TR and would be more TMVR. The next step, and why the anatomy of the mitral valve leaflets and subvalvular apparatus are important to consider, is once you decided, okay, TR is a good option for this patient, and for example, here you decide to use mitral clip, you can use this criteria to decide which type of clip you're going to use, the NT, the NTY, the XT, or the XTY. So some example here of patient with severe secondary MR that you can appreciate here. So we're going to measure the extension of the jet. You see here that is pretty long, around 10 to 11 millimeter. And the leaflets are not calcified. It's essentially a pathology that is dominant in segment 2. You can appreciate again here the MR. So there are several criteria that are met in the green light. So central pathology in segment 2, no leaflet calcification, mitral valve opening area that did not show, but obviously more than 4 centimeters square. The mobile length of the posterior leaflet was more than 10 millimeter. The coaptation depth, which is an important parameter, is less than 11. So several criteria in favor of TR. There is one that is kind of in between, which is the Carpentier 3B, but that's most of the case in the secondary MR in this category. So in this case, we decided to do a TR. And so a mitral clip was selected as device. And given the wide elongated jet that I showed you, we're going to use a wider device. And because of the other criteria mentioned here, we're going to use a longer device. So it's going to be the XTY that is going to be selected. So showing here first clip. Often when you have some criteria that are in the orange, you often have to use 2 clips, and indeed there was some residual MR after the first clip, so putting here a second clip, and now much better. You will see on the right, sorry, the final results that shows just a trace to mild residual MR. So for primary MR now, what are the guidelines? Well, there are maybe less criteria and step than for secondary MR. So if you have patient with, again, chronic severe primary MR who are considered inoperable or high surgical risk and who are anatomically suitable for TR without extended heart failure, with extended heart failure after extended heart failure treatment, let's say, then this could be a good candidate for TR. So I summarize here again. So severe chronic primary MR and symptoms, extended heart failure treatment has been accomplished, inoperable or higher surgical risk, treatment non-considered to be futile by the heart team as usual, and again considered anatomically suitable for TR. And we're going to use the same, anatomic criteria that we previously described for secondary MR. So showing here an example of a mitral valve prolapse, as you see here, and some significant primary MR. Here is the flail width that is pretty wide, actually, 2.18 centimeters, so more than 2 centimeters. This was the measurements of the length of the mobile portion of the posterior leaflet. The leaflets are not calcified. Again, this is more a P2 prolapse here. So a priori, if we summarize with the table, central pathology in segment 2, no leaflet calcification, mitral valve opening area, okay. The mobile lengths of posterior leaflets more than 10, coaptation depth less than 11. So the only criteria that is in the orange, more like hesitating, is this flate web that was more than 15 millimeter, actually more than 20 millimeters. So you know that if you go with TEER, you'll probably need more clips, more than one, but I think it's reasonable. And there are some criteria for using a wider clip here because of the flate width more than 15 millimeter, and again, wider and longer. So again, in this case, we're going to use the XT wide, XTW. This is after first clip. Good results, but I think need more. So this is the first clip in place. And after the first clip, we check for the iatrogenic mitral stenosis, mean gradient of 2, pretty good. So no evidence of mitral stenosis. Putting a second clip now, and again after the second clip, no mitral stenosis. Mean gradient in the 2, very stable, and pretty good results that I can re-show here. You see with really only a trace MR after the placement of these 2 clips. So if we summarize, the criteria for patient selection for TEER, for M-TEER. For primary MR, first you need severe chronic primary MR, defined as EROA more than 40, reduction volume more than 60, reduction fraction more than 50%, and symptoms. Needs to be symptomatic severe MR. Patients who are considered inoperable or high surgical risk, who have had an extended heart failure treatment, so medical therapy for heart failure, although there is not much for primary MR, treatment not considered to be futile, and finally, which is common for both primary MR and secondary MR, anatomically suitable for TEER. So I've summarized the key criteria here: central pathology in segment 2, no leaflet calcification, mitral valve opening area more than 14 centimeters square, coaptation depth less than 11 millimeter, mobile length of the posterior leaflet more than 10, and the flate width less than 15 millimeter. And for secondary MR, same persistent severe secondary MR, but here the criteria for severe MR is somewhat different. It's more moderate to severe, if you will. EROA more than 30, reduction volume more than 45, and reduction fraction more than 50 or 40, depending on the studies. Not eligible for surgery. No evidence of end-stage LV or RV failure and dilation, and fulfilled criteria for likelihood to response to TEER, which include the disproportional ratio of EROA to LV and diastolic volume more than 14, LV and systolic diameter less than 70 millimeter, that was a co-op criteria, LV and diastolic volume index less than 140 ml per meter square, and LV ejection fraction more than 20%. You don't need all these criteria, but I think, the more you have criteria in this category, the more the likelihood will be of this patient to respond to TEER. Thank you so much for your attention.
Thank you very much, Professor Pibarot. This was an excellent lecture, really, focusing on most things. Due to time, I think we will proceed with the following talk, and then maybe you could stay with us for a few more minutes. We kindly request all our speakers to try and keep in time so that we do not enter too much onto the next session. So, Dr. Patakos, would you continue presenting, please?
Yeah, Dr. Makriyanis will present the next speaker.
Good morning from me. We're moving to the next presentation.